Welcome back. Now we will be discussing in more detail some of the circuit components. This is a list of the circuit components as they are written in most of the books. We will start with the aortic cannulae. So just a brief word here of advice that in the past the aortic cannula was made on table. So the scrub nurse used to have a set of certain ends, bodies, additives, and she would make it up according to the preference of the surgeon. Nowadays, aortic cannula are pre-made. They come already manufactured with certain features. You can select the type of cannula. Academically speaking, theoretically, when we study the types of cannula, we study them as characters of the tip, the body, and the additives. However, that's no longer the case. So there is nothing like a right-angled cannula per se only. That's all. No, you will find a cannula which has multiple features such as a soft diffusion tip, as well as wire reinforced, with a flange, without a flange, with a donut, without a donut, and so on. Now let's start with the tip of the cannula, the form of the tip. There is right angled and straight. Right angled has the benefit of not hitting the back wall. It's safer in insertion, especially in smaller aorta. However, it has the drawback of susceptible to selective flow. So you can easily direct the flow into one of the arch vessels, not the rest of the arch. On the other hand, the straight cannula is more likely to hit the back wall if you're not careful, of course. Yet there is less likely to it's less likely to create selective flow. Then we have the shape of the tip as well, the bevel tip and diffusion tip. It is of note that the tip of the cannula is where the maximum flow acceleration happens. That's the most obstructive point of the cannula, and hence the shape of the tip will determine the peak gradient generated across that. Bevel tip cannula create higher flow acceleration, they create higher gradient, and hence more likely to create jets which dislodge atheroma or plaques in calcified aorta. Yet it is easier of insertion because it looks like a dagger, so it's easier to put it through the aortotomy. Yet the diffusion tip on the other hand side is creates less flow acceleration. As you can see here, it creates less flow acceleration, less peak gradient, less likely to dislodge atheroma and plaques, yet it's in the view of some surgeons more demanding in insertion. Of course, it's completely relative. If you are doing it every day, it will be easy in your hand. If that's the cannula you use every day, it's easy in your hand. This is just relative. Then the body of the cannula may be wire reinforced or not, or standard as we call it in practice. So wire reinforced cannulas provide you with higher flow to a certain size. So for instance, a wire reinforced 18 French cannula will provide you with higher flow than an 18 French cannula of standard size. Yet it's smaller in size, and hence less occupying space, and hence less obscuring of your field. For instance, if you are operating on a short aorta, small aorta, or you need to cannulate the arch, for instance, you will benefit from a smaller size cannula, yet you don't want to lose the flow, hence using wire reinforced seems to be a good idea. Then you have the flanges and donuts. As you can see, this is one of the ways to anchor the cannula to the aortic wall. Donuts also provide you with a distance, safety distance, so it doesn't push against that. And again, it's completely relative. In aortic cannulation, there may be central or peripheral cannulation strategies. We will not go into that in details now. We will be discussing that in more details in aortic surgery. Just a brief point of you may be cannulating centrally through the chest or peripherally through the femoral, axillary, or carotid areas. We'll discuss that later on in aortic surgery section. Now, as you can see, in aortic cannulation, the types of cannula are subject to the preference of the surgeon. Different cannula provide you with different benefits, and it's up to the surgeon to decide which cannula to use. On the other hand, venous cannulation, the venous cannula types are suited for different strategies. These strategies are made for different kind of surgeries. So you decide which cannula to use depending on what strategy of cannulation, venous cannulation, you will be going ahead with, and this will determine, this is to suit a certain surgery you're doing. We will explain that more now. So the first type of cannula is a two-stage cannula in which there are holes in the body as well as the tip of the cannula. This is used in cavoatrial cannulation, and this is more suiting certain surgeries such as, for instance, AVRs, cabbage and AVRs. It's a very easy mode of cannulation. Next is the one-stage cannula in which the holes are at one stage only, are at the tip of the cannula. And this is also one of the cannulation in which you use for bicaval cannulation indirectly. Indirect means you are putting your purse strings on the atrium, not on the cavae. So you're leading the cannula through the atrium into the cavae. There is holes at the end of the cannula. You are cannulating both sides. Both cavae are cannulated, as you can see here in the diagram. The other type is the one-staged right-angled cannula. In this modality, there is holes at the one stage at the tip of the cannula, but you're cannulating directly the both cavae. So you're putting your purse strings on the SVC and the IVC. That's what we call the direct bicaval cannulation. Historically speaking, the Ross basket, I brought you one here. It was a bit difficult to find. This is a Ross basket. It was historically used, not commonly used these days. It's an historical point. So when do we use these various forms of cannulation? As I said, so different surgeries will require different strategies of cannulation. It all depends whether you are opening the right side, whether you need to fully decompress the right side or you're not. So just in brief, for instance, if you are the drainage of the right heart will achieve one, fully decompression, avoids distension, avoids coronary backflow. This is extremely crucial. Of course, it's beneficial in all types of surgeries. However, it's extremely crucial if you are opening the right side, for instance, in tricuspid valve surgery, VSDs, ASDs, to completely empty the right side, to completely drain the right side of the heart. Hence, you need direct bicaval cannulation. If you are not opening the right side, however, you will benefit from an empty right side, for instance, in turning the heart around or approaching the left atrium, for instance, and you need to turn the heart without having the issue of kinking the venous cannula and hence obscuring the venous return, you might consider the indirect bicaval cannulation. If you are not accessing the right side, if you don't want to reach the left atrium, for instance, in cabbage AVRs, you might consider cavoatrial cannulation. This is only, again, relative. Some surgeons, for instance, do bicaval cannulation in all surgeries, whether cabbage, AVRs, MVRs. That's to achieve the benefits of decompressing, reducing distension, reducing rewarming. However, as we explained, potential kinking is a very important here point to bear in mind. If you are going to approach the left side of the heart, you must be very aware that you need a cannulation strategy which is not going to kink your venous cannula and reduce your venous return. In that essence, the best mode of cannulation, which is completely resistant to kinking, is the direct bicaval cannulation. Cavoatrial is the least resistant. Selective indirect is halfway through between, depending on the anatomy and the anatomy of the chest and anatomy of the heart. And you must bear in mind also the technique difficulty. So, relatively speaking, direct bicaval cannulation is the most difficult. Least difficult is cavoatrial. I must emphasize here that this is completely relative. If you are a surgeon who every day cannulates directly bicaval, it will be easy in your hand. So that's relative. If you are not used to it, you're not doing it on a daily basis, it will be more difficult. Again, it's a matter of preference and variable between one surgeon to another. Generally speaking, cavoatrial is the easiest. Selective direct is the most difficult, and selective indirect is halfway between. So again, let's revise in brief. If you are doing a surgery, you need to access the right side of the heart. As you can see here, in the direct in the direct bicaval, you are completely emptying the right side. You have no tubes in the right atrium. You can easily access the tricuspid valve, do a VSD, do an ACD. You are having the right atrium fully empty, fully free of any tubes. If you are, however, operating on the left side, doing a mitral valve surgery, for instance, and you need to turn the heart, you are worried about a venous kinking, cavoatrial is not the best way. The best way is one stage. Again, it's relative. You might find yourself in a situation in which you are doing cavoatrial, provided you are not going to do a concomitant tricuspid valve surgery. So you are doing bicaval cannulation indirect. You're emptying the right side of the heart. However, the tubes are still in the right atrium. So you have obscured field if you're going to access the tricuspid valve or access a VSD or an ASD. So in mitral valve surgery, you might consider cavoatrial. Indirect bicaval cannulation. If you're doing a CABG, AVR, you don't need fully decompressing of the right side. You don't need the difficulty of the direct venous cannulation. You might consider cavoatrial cannulation. Having said that, some surgeons sometimes routinely go for bicaval cannulation, indirect, of course, not direct, for all cases, to achieve better decompression, to achieve risk rewarming, and achieve and be able to achieve better drainage of the coronary backflow, less obscuring of the field, better technique. Okay, this is the venous cannulation. Now going to the oxygenators, there are two types of oxygenator. One of them is mainly historical now. It's rarely used or not used at all. Is the bubble oxygenator. The oxygenator which is most commonly used today is the membrane oxygenator. I've got one in here. As you can see, this is the membrane oxygenator. It's called a membrane because, as you can see here, there is a membrane inside. This is the exchange membrane, which the gas exchange occurs at. The membrane oxygenator has the benefit of, one, having less SIRS effect. In the era of bubble oxygenator, every time there is a blood-gas interface between any bubble produced, creates a new gas-blood interface, and hence increasing the effect of the SIRS effect. In membrane oxygenator, the first few seconds this occurs, yet later on during bypass, the plasma membranes cover the membrane and hence reduce the gas interface, the blood-gas interface, and hence reducing the SIRS effect. Also, as you can see, it is suited with multiple ports, and the effects and gas control in this membrane oxygenator is much easier, whereas in the bubble oxygenator era, changes take time before they elicit themselves. Also, a less incidence of microemboli with the bubble oxygenator, membrane oxygenator. The bubble oxygenator has higher incidence of microemboli. The only drawback of the membrane oxygenator is more expensive. Next, we have the reservoirs. Again, one of the types is less used these days is the closed containers or reservoirs. Most commonly used now are the closed reservoirs, or they are called hard reservoirs. As you can see, they are hard. The closed reservoirs were made of materials resembling a blood bag. Now, as you can see, it's first of all cheaper than the other reservoir. Second, priming and managing the drainage was easier. As you can see, it's full of ports. There are markers. You can easily see the level. You can put a level detector controlling level. This was all not available in the closed container. Also, you have better control because you're having more sampling ports, as you can see here, which was not again the case in the closed container. The only problem is it has more SIRS effect because it has higher surface area, so there is a bigger interface and increasing the SIRS effect. Then the pumps. We are all familiar with the roller pumps. We have a different types of pumps which are actually used. They are not completely out of use, which is the centrifugal pump. If you look here carefully, there is a centrifugal disc inside which runs around. It creates the centrifugal force which drives the cycle. Now, the way this used to operate was Blood goes in through a siphonage, and it's a closed compartment. It creates the roller effect, and the centrifugal force keeps it running, and that's how the the blood goes around. The problem with this, it's dependent on the pressures on either side. So if the pressure is higher after, it will slow down. Lower blood pressure, again, very low blood pressure will slow it down. So it's highly dependent on the pressure afterward. The roller pump is run by the machine. So you set the flow rate, you set the revolution rate, and it does it regardless what's after, what's the afterload, what's the pressure beyond it. Of course, there are pressure detectors which stops the pump if the pressure goes too high. So academically speaking, theoretically speaking, the roller pump was more susceptible to occlusive. It's an occlusive circuit. The pump is hitting regardless what's running after, what's happening beyond the circuit, and hence it's an occlusive circuit. It has the there is a possible risk of breaking the pump or breaking the pipes, whereas in the centrifugal there isn't this effect. The problem is the centrifugal is dependent on the afterload, which makes it at risk of a backflow. So if the pressure gradient across changes, this might cause backflow, and also it's not possible to perform pulsatile flow. It goes on and on. In the roller pump can imitate the pulsatile flow, and it's not dependent on the afterload. As we said, the roller pump is an occlusive circuit, so it creates more hemolysis, whereas in the centrifugal pump it does not. Finally, this is an MCQ just to test your knowledge. I hope you benefit from this section. I will leave you with that, and we'll be starting the next section, which is pathophysiology of cardiopulmonary bypass. Thank you.